neat. The sound was there when he woke up, not outside the room, inside his head. Every time his eyes moved, he heard it, a low, wet grinding, like something shifting behind the bone. He mentioned it to his wife. She heard nothing. He was in his late 40s, a teacher, by most accounts, a practical, grounded person. His life was ordinary in every measurable way. He went to work, came home, slept reasonably well. But the sounds had started months earlier, quietly at first. A faint swooshing when he turned his head too fast. A thump when he walked downstairs that seemed to come from inside his skull. Then the eye movement sound arrived and did not leave. He made an appointment with his general practitioner, who referred him to an audiologist. The audiologist found mild hearing changes in his left ear. Nothing that explained a grinding sound tied to eye movement. He was referred on, but the symptoms did not stop. The first specialist ordered standard tests: audiogram, tympanometry, otoacoustic emissions. The results came back largely within normal limits. There was no obvious structural damage, no tumor on the auditory nerve, no middle ear infection. He sat in the office and described what he was hearing: the grinding, the thump of his own footsteps, the sound of his heartbeat when the room was quiet. The physician documented his symptoms and noted that anxiety was a possible contributing factor. He was given a pamphlet about noise sensitivity and tinnitus management. He went home and tried to explain to his family why he still had no answers. Over the following year, the sounds grew more specific. He could hear himself chew on one side of his jaw, but not the other. He could hear his own voice reverberating inside his head when he spoke, a condition later documented as autophony. Loud external sounds had started to produce dizziness. A door slamming nearby would briefly unbalance him. He began avoiding busy restaurants, not because of anxiety, but because the background noise was physically disorienting. A second audiologist noted the autophony and the sound triggered dizziness and used a phrase he had not heard before. She wrote it in her referral notes: possible third window phenomenon. He did not know what that meant. The referral sat in the system for 3 months. He had begun, by that point, to question his own account of things. Every professional had been thorough. Every professional had found nothing definitive. If the tests kept coming back normal, maybe the sounds were something he was amplifying, something stress-related, something manageable, with the right mindset. He tried to approach it that way for a while, but the grinding of his eyes in their sockets was there every morning. That part was harder to explain away. Now here is where the medical records become unusual. When he finally saw a neurotologist, a specialist in disorders at the intersection of neurology and the inner ear, a specific test was ordered that had not been done before: a high-resolution CT scan of the temporal bone with thin slice imaging. Most standard CT protocols do not capture this region in sufficient detail. This one did. The scan revealed a gap, a small but definite dehiscence, a thinning or opening in the bone of the superior semicircular canal on the left side. It was less than a millimeter in most estimates, but it was there. The physician reportedly said he had seen perhaps a dozen cases in his career. Superior canal dehiscence syndrome, a condition documented in medical literature since 1998, when neurotologist Lloyd Minor and colleagues first described it in a published case series. The superior semicircular canal is one of 3 fluid-filled loops in the inner ear responsible for detecting head movement. It sits beneath a thin layer of temporal bone, the bone at the side and base of the skull. In superior canal dehiscence, that bone layer is absent or eroded, creating an abnormal opening. This opening becomes what researchers call a third mobile window in the inner ear. The cochlea and semicircular canals are designed to function with two specific pressure points. A third unintended opening disrupts the hydraulic balance of the entire system. Sound energy that should drive cochlear fluid toward the hearing receptors leaks instead toward the dehiscence. The result is a simultaneous increase in sensitivity to internal body sounds and a reduction in the ability to process some external sounds normally. This is why patients hear their own heartbeat, their own chewing, their own eyes moving in their sockets. The sounds are real. They are conducted through bone directly to the inner ear fluid. According to published research, superior canal dehiscence affects an estimated 1 to 2% of the general population to some degree, though symptomatic cases requiring medical intervention are considerably rarer. Studies suggest the average time from symptom onset to correct diagnosis has historically been between 4 and 7 years. This case fell within that range. Clinicians initially believed the condition was primarily congenital, that patients were born with abnormally thin bone in this region. More recent research has proposed that the thinning may develop progressively over time, potentially triggered by increased intracranial pressure, prior head trauma, or chronic strain on the temporal bone. What remains poorly understood is why some individuals with thin bone in this region develop symptoms, while others with equivalent thinning do not. Studies using functional imaging have not yet produced a definitive answer. Treatment options depend on symptom severity. For patients with mild symptoms, conservative management, avoiding triggering sounds, reducing exertion, adjusting activities, can provide meaningful relief. For patients whose symptoms significantly impair daily function, surgical repair is available. The procedure involves either plugging or resurfacing the dehiscence through a craniotomy or a procedure through the ear canal. Documented outcomes in published case series indicate that the majority of patients who undergo surgery experience substantial reduction in autophony and sound-triggered dizziness. Hearing outcomes vary. Not every patient achieves full resolution. Researchers note that the longer the dehiscence has been present and symptomatic, the less predictable the recovery. And then came a finding that changed how physicians understood this. What this case exposed was not a failure of any individual physician. Every clinician who saw him followed standard protocols for their specialty. The gap was in the imaging. Standard CT scans of the head do not routinely include thin-sliced temporal bone imaging. Without that specific protocol, the dehiscence is invisible. It looks like normal bone. Since Lloyd Minor's original 1998 publication, awareness of this condition has grown within neurotology, but it remains underrepresented in general practice training. Primary care physicians and general audiologists may not include it in a differential diagnosis because the symptoms, autophony, sound-triggered dizziness, a sense of internal amplification, overlap significantly with more common presentations of anxiety, tinnitus, and Meniere's disease. What the patient described as a quality of life issue had, over several years, become something more. He had reduced his social activity, modified his work environment, and spent a significant period believing the problem was partly self-generated. That last part, the self-doubt, is documented across multiple published patient accounts of this condition. It is one of the more consistent features in the literature. The symptoms are invisible on a standard workup. The patient is told there is nothing wrong, and at some point, many patients begin to believe it. What this case reveals about medicine is not that it failed, but that the diagnostic pathway for certain conditions depends entirely on whether the right specialist asks the right question and orders the right protocol. Superior canal dehiscence cannot be found unless someone knows to look for it. That is a systems problem, not a physician problem, and it is slowly being addressed through updated clinical guidelines, through greater inclusion of the condition in otolaryngology and neurotology training, and through patient advocacy from those who eventually received a diagnosis and chose to speak about it. He went through with the surgical repair. According to the documented case outcome, the grinding sound linked to eye movement resolved in the weeks following the procedure. The autophony reduced substantially. The sound-triggered dizziness diminished. He described the quiet, afterward, as something he had not expected to feel emotional about. Every morning, the sound was there, not outside the room, inside his head. A small gap in a bone most people never think about, and it changed the way he heard the world. If you had spent years telling doctors what you were hearing and every test came back normal, would you have kept believing what you knew to be true? This video is based on real, publicly documented medical case reports and is intended for educational and storytelling purposes. It is not medical advice. If you or someone you know is experiencing similar symptoms, please consult a licensed physician. Medical mysteries, true cases every week.